Alrighty, excellent. So as mentioned, I'm an associate professor and also work as a nurse practitioner in the Healthful Eating Activity and Weight Program, which is the obesity treatment program at Johns Hopkins. And this is my funding and disclosure slide. I also have a branch of my research that is working on anti-obesity medication. So you can see that I've consulted for some pharmaceutical companies, highlighted here, Eli Lilly and Company, Epitome Medical, Novo Nordisk, and have also worked with Weight Watchers. And today I'll be talking about some of my research that has been funded by the Edna Kynette Memorial Foundation, as well as NINR, National Institute of Research, particularly an R56 study. So my world is focused on obesity treatment. And as a reminder to all of you, obesity treatment is typically thought of as a pyramid where lifestyle modification really forms the foundation of all of treatment. This includes things like improving diet, increasing physical activity, as well as behavior modification strategies. And I did not plan this with Grace, but Grace had this in her slides as well. But I wanted to highlight here that social determinants of health really plays a key role in terms of all of these facets of obesity treatment, ranging from whether people even have access to their treatment. You know, insurance coverage has been a struggle for a lot of individuals seeking anti-obesity medications. But social determinants of health also has a really big role in terms of thinking about treatment for lifestyle modification. And this is really important too, because as we think about social determinants of health, studies have demonstrated that individuals who experience more adverse social determinants of health have a higher risk of developing obesity. So again, a really big patient population need. So in terms of taking action as a clinician, one of the things that has been really highlighted by a lot of different guidelines has been screening for social determinants of health. And this has been also included in different mandates from places like the Center for Medicare and Medicaid from CMS. In order to assess for individual social risk factors in healthcare settings, there are a number of different initiatives that have been taken place, including things like health-related social needs screening tools and embedding these into EMR, and getting providers to screen for these different risk factors. And this is, again, an example of one. And another example, too, is using Z codes. So Z codes are social determinants of health related codes that can document different things like housing needs, food insecurity, as well as transportation. Again, highlighting and recognizing the importance of these factors in terms of patient treatment as well as risk factors. So one area that I am particularly interested in, especially in regards to obesity treatment, is food insecurity, which is defined as limited or uncertain availability of nutritionally adequate and safe foods, or limited or uncertain ability to acquire acceptable foods in socially acceptable ways. For the screening, it can be done by two short questions. Within the past 12 months, you worried that your food would run out before you got money to buy more, or within the past 12 months, the food you bought just didn't last and you didn't have enough money to get more. So again, these screening measures are pretty short to be able to implement in practice. And again, highlighting this relationship in terms of the context of obesity, we know that about 42% of individuals with food insecurity have obesity. And it can create a cyclical cycle where individuals with food insecurity might have difficulty accessing food. They might be more likely to have things like depression or mood disorders, live in maybe physical activity deserts where they don't have access to green spaces or sidewalks to walk around. They might be relying on fast food more. They might have less healthcare utilization. This can also contribute to things like using food to maybe cope with different emotions, less bandwidth to focus on physical activity, which can contribute to chronic diseases like type 2 diabetes, high cholesterol, which might increase healthcare expenditures, decrease employability, lead to less household income, and then spending trade-offs where individuals might be choosing between, say, picking out healthy groceries or being able to afford medications. And then again, it can continue with this cycle over time. We also know that food insecurity is associated with worse weight loss during weight loss programs. And this has been replicated in a few different studies. And part of the reason why this is that intensive lifestyle intervention or lifestyle modification, which again forms the foundation of that pyramid, focuses on different things like dietary changes and caloric restriction, which is induced and maintained through increases in low energy density foods, things like fruits, vegetables, lean proteins, and then decreases in foods with high energy density or high calories. We also emphasize things like physical activity as well as different behavioral modification strategies, as you can see. However, it does little to really address different social determinants of health, which is a huge gap in terms of really being able to help patients in need. We know that food insecurity and food affordability are tightly influencing factors related to people being able to adhere to different treatment strategies that we might be advising them in clinic. So less energy dense foods like fruits and vegetables are more costly. And the monetary amounts provided by different nutrition assistance programs are oftentimes insufficient to be able to cover the cost of adhering to things like federal guidelines for healthy diets. In addition, about a third of people who experience food insecurity don't qualify for federal food assistance. So again, a lot of patients in need who might not be able to access resources. We also know that oftentimes foods that are less energy dense, fruit and vegetables, are harder to access, especially in different areas where there might not be grocery stores or where there might be a high number of individuals who don't have access to vehicles or cars to be able to get to grocery stores. So we know that living in a food desert and or a food swamp limits access to nutritious foods. And food swamps are places where there might be a lot of places like corner stores or convenience stores or fast food restaurants. And these really are overcrowding access to healthier foods. So if you think of yourself as a clinician screening for food insecurity, and you have someone who answers that they might be experiencing food insecurity, and they're also interested in losing weight to improve maybe different health outcomes like type 2 diabetes risk or blood pressure or improving obstructive sleep apnea, what do we do for these patients? And this has been a struggle, I think, and why the adoption of some of the things like Z codes has been suboptimal in some settings. It's because if you screen it and don't have a lot of tools to be able to address it, then it can be really frustrating for providers. So these are some different options that people might think through. So can we tailor care? So this might include things like focusing more on low budget fruits and vegetables, using frozen produce, making sure people are really being able to stretch their dollars in terms of their nutrition. Referrals and connections. So these could be sort of passive referrals where individuals might have, say, a list of resources in the EMR that are sent to the patient or printed off at the end of the visit, or active referrals, which tend to result in better resource linkages, where there might be an individual who actually is able to help someone to be able to navigate and really connect with the different resources like a food pantry, or help them register for something like SNAP or WIC. And then a big gap in terms of obesity treatment is the provision of resources. And this brings me to a review that I did looking at food insecurity and behavioral obesity treatment to kind of look at what is the evidence behind different practices that are being done to address food insecurity within obesity treatment. And for this, we only found 5 studies, so there wasn't a lot of evidence. And much more is needed. So there were 2 main types of interventions that were being done. One was obesity treatment counseling with and without tailoring for food insecurity. And then the other was different subsidies to increase food access. So 2 of the 3 studies included counseling alone, and these were essentially to see if individuals lost less weight during behavioral weight loss, one of the studies I showed before. And then 3 of the 5 studies included interventions to increase food access. So this included things like subsidized membership to a community agricultural group, grocery store gift cards, or using meal replacements. But there was really a lack of studies that evaluated behavioral weight loss treatments or lifestyle modification programs, plus food as medicine approaches. So food as medicine approaches can take a variety of different forms. And these are interventions that are really focused on recognizing that food is an essential part of health, and that oftentimes clinicians might be counseling patients to have healthier diets, but patients might not have the resources to be able to do this. So what can we do clinically? At the population level, there's different healthy food policies and programs. There's government nutrition security programs, produce prescription programs, medically tailored food package, and medically tailored meal programs. So there's pros and cons in terms of thinking about challenges like scalability as well as sustainability, kind of thinking about the efficacy for each intervention and condition. Here we're talking about obesity treatment, so it'd be looking at weight loss as well as other chronic conditions related to weight. Things like cost of the program. Obviously, the medically tailored meal programs tend to be fairly expensive, oftentimes because these might be frozen foods that might be delivered to individuals. So cost is a big factor. Again, how scalable it is, how willing are people able to adhere to different types of programs, as well as things like sustainability. So again, highlighting some of my research, I'm just going to go very briefly over some of the studies that I have done. One is looking at different produce prescription programs, and this was funded by the Edna Kynap Foundation. We call this the Produce RX pilot study, which was to examine the feasibility and preliminary effects of a program that combined these food bucks that we got from the Food Trust in Philadelphia, combined with a behavioral weight loss program compared to waitlist alone. It included weekly 30-minute individual in-person lifestyle counseling sessions with content tailored for individuals with food insecurity. And then individuals were provided with $20 at each session. This is highlighting the adherence. So we had fairly good adherence for people coming to their sessions. So the mean was 10.5 out of 12 sessions attended, and individuals used 67.5% of their food bucks, which were redeemable at select farmers markets as well as grocery stores. These, I'm not going to show a ton of data, but just wanted to highlight that the total score for their actual dietary quality, which was measured using 24-hour dietary recalls, numerically increased in the Produce RX 3.9 points compared to the wait list, but it wasn't statistically significant. And then you can see here that both groups had declines in calories. We did see differences in terms of weight. So for the Produce RX group, they had a weight loss of 2.4% compared to the waitlist group who had a gain of weight. And then there was greater improvements in weight control efficacy in the Produce RX group, as well as greater improvements in physical health-related quality of life. So what this showed is that the program demonstrated preliminary feasibility and efficacy compared to the waitlist group. The Produce RX group produced an improvement in dietary quality, but was not statistically significant. And we did find improvements in weight control, self-efficacy, as well as health-related quality of life. This next study, I'm just going to show you a little bit of the design. It's a preview. We're currently analyzing the data, but this was funded by the National Institute of Nursing Research. And this was called the Food RX pilot study. And this particular study was geared towards the fact that oftentimes, as I showed before, we have this food as medicine pyramid, but we don't know which food as medicine approach might be better for certain outcomes. And again, this has really big implications for thinking about sort of scalability as well as long-term feasibility and sustainability. So this is looking at whether food supplementation interventions improved weight loss, health-related quality of life, and dietary quality in individuals with obesity and food insecurity. And again, looking at what type of food supplementation intervention is most effective. And for this, we have a group that's randomized to behavioral weight loss alone, again, geared towards increasing knowledge, skills of how to change diet, which hopefully is going to increase behavior change and dietary quality and improve weight loss.
Dr. Chou, there's 3 more minutes. Sorry to interrupt, but 3 more minutes.
No, thank you for the time reminder. And then there's a behavioral weight loss and voucher group, which again has increased knowledge. And then the voucher hopefully will increase the salience of importance of eating nutritious foods, because individuals are given a a gift card to a grocery store, and they're able to go through with their counts. There are different fruits and vegetables that they might be able to purchase with the gift card, but they have more flexibility in terms of what they're actually spending it on. And again, it helps to remove the cost barrier to nutritious food. And our last group is focused on a behavioral weight loss intervention plus home delivered groceries. So this can not only address these other barriers that I introduced before, but also increase the convenience of nutritious foods, which might be important, especially for individuals who might be living in food deserts or food swamps. So this is the study schema. So we'll be looking at changes from baseline to 24 weeks. And again, the results are coming soon, so hope to be able to share those with you soon. But in conclusion, for food as medicine, in terms of thinking about obesity treatment, there's a clear in terms of evidence-based gap that's needed to be addressed. And in order to do this effectively, we really need studies that are larger samples, looking at longer treatment, looking at things like sustainability, both at a patient level, how long do we need to provide the food supplementation for? And then if food supplementation stops, are patients able to sustain different behavior changes long term? Also looking at things like site level factors and the availability to implement these different programs inside of clinical settings. And lastly, I think Grace really cued this in, but the importance of thinking about different pathways to policy, really thinking about nurses who are able to advocate for these sort of initiatives to be implemented in healthcare settings as well as federal programs. So with that, I'd like to thank you all so much for your attention. I'm looking forward to the discussion.